Jacob, welcome. Excited for conversation today. For folks joining in, Jacob is the Chief AI Technology Officer for CMMI, the Innovation Center as part of CMS. Jacob, y'all seem busy these days, working on a lot, getting new programs out there. Access, in particular, had two programs or announcements last week, one of which caught the attention of the industry around rates, the other around payer participation in the model I thought was equally as interesting and hope we get to dive into in this conversation today. Before we get into the conversation, I'd like to open the floor to you to say hello, background, what CMMI is up to, and in particular, the thesis around access as a whole. I mused a little bit on this in the newsletter. It's interesting to think about kind of the intersection and the vibes I get from CMMI of this being kind of transformational point in American healthcare, obviously technology encouraging us to rethink how we conceptualize how care is delivered. There's the general MAHA narrative, and I've heard RFK talking about getting wearables to everyone in the country over the next several years. And then there's all the conversation that Oz and others have mentioned about convening the industry together to drive this change. And I'd be curious how that's showing up in CMMI broadly and access in particular.
Yes, certainly. It's great to be here speaking with you. Big fan of the community. So first I'll briefly introduce myself as well as the Innovation Center and then jump into the substance of the conversation. So I serve as Chief AI and Technology Officer at the Innovation Center. In my role, I'm particularly focused on how can we evolve how we pay for healthcare to enable the fullest potential of technology to meaningfully improve health and reduce costs. I often think about my role as being what's possible when it comes to technology and care delivery, what's the status quo today, how do we bridge that gap? And I think many people who are listening to this conversation will know that incentives are really our king. Technology is no longer the barrier, or at least not in the way maybe it has been historically. It's really about, is there a reason to adopt these technologies, and is there other things holding it back? And I happen to sit at a very unique place within the government, which is at the Innovation Center that has what I consider to be this superpower, which is the ability to, at scale, rapidly test new ways of paying for care. So that's my role overall. I am not a suit government guy by disposition. I joined about 8 months ago. Before that, my background is much more in the community. I started and led a venture-backed startup called Anomaly, streamlining the health insurance billing and payments process. Worked at other companies in the health tech world, Flatiron Health, Redesign Health, and started my career at Google. So sort of uniquely have both the operator founder hat as well as now the policymaker hat. Relatedly, so you asked about how the model came to be, the access model. So first of all, a term of art in the world of CMI, model does not mean an Excel sheet. It does not mean an AI model. It means a program, essentially. And the access model came about really from direct conversation with what's happening in industry. I spoke to hundreds of organizations and asked them typically 5 questions in some way or another. What do you do? Who's your customer and why do they pay you? How do you get paid? What's working and what's holding that back? And some pretty clear themes came together pretty quickly. The problem statement we all know. So basically, there's unfortunately a crisis of chronic disease in this country. America's health is not what it needs to be. The good piece is that the technology has the potential to meaningfully improve people's health. And that was clear from these conversations in terms of how technologies are able to be adopted. The challenge was that today's existing payment options really do not accommodate technology-enabled care, and they really don't reward that. And that's because, to be a little more specific, on the one hand, of course, we have fee-for-service that pays for very specific activities. If the way that you deliver care does not map to one of those winning activities, you're out of luck. And incidentally, it's our belief that adapting the fee-for-service, pay-for-activities framework for technology-enabled care, which is not supply-constrained, is the wrong approach because it is likely to explode utilization without necessarily having the value to show for it. And you have to define, well, what are the activities you will and won't pay for, thereby further constraining innovation. So that whole construct is likely not the appropriate one for technology-enabled care. On the other hand, shared savings approaches do better align incentives. But the challenge that I heard time and time again is that it's very difficult to determine, well, what are the savings that are associated with a new way of treating diabetes or a new way of treating depression? And the reality is that it's difficult, if not impossible, to do that which ends up creating this contracting friction that in practice means that all these great new solutions that exist today and will exist tomorrow are not able to be adopted in practice, certainly within the insured population and more generally within how people receive their care today. And that's really the gap that the access model was looking to fill by introducing a new payment option, which we call outcome aligned payments, that rewards outcomes rather than activities and gives organizations a flexibility around how they achieve those outcomes, including through the use of technology. It's really a whole new way of paying for healthcare in many ways, specifically focused on chronic disease. So the way this works in practice is that an organization, if they're already enrolled in Medicare, they're good to go. If they're not yet, they need to enroll in Medicare as a provider or a supplier. They designate a physician medical director. And then at that point, they are now able to enroll patients into a clinical track for which the patient has a qualifying condition. So tracks are basically groupings of conditions that are typically comorbid, have shared types of interventions. So there's 2 tracks in the cardiometabolic health space, one called the ECKM, or early cardio-kidney metabolic track for prediabetes, obesity, hypertension, and dyslipidemia. Another track, the CKM track for diabetes, heart disease, essentially, and early chronic kidney disease. A third track in the musculoskeletal health space for chronic MSK pain, and then a 4th track in the behavioral health space for depression and anxiety. Across those tracks, we announced that 70% of Medicare beneficiaries have at least one qualifying condition. So this is a huge market opportunity. If you're not, a niche orphan diseases. So an organization can sign up a patient directly into a track. The patient can sign up directly with the organization. They can also be, of course, referred into it by a clinician. And we'll talk about the things that we're doing to really support that integration. The first thing the organization has to do when they sign up the patient is understand where are they starting. So what is there in the case of the ECKM track? What is their starting blood pressure, A1C, LDL-C, and weight? They then deliver care each month. They have the flexibility around how they choose to deliver care, whether that's a fully autonomous, compliant application, whether it's a hybrid approach, whether it's traditional care delivery. They have the flexibility around how they choose to do so within the bounds of licensure, HIPAA compliance, and the like. They submit a single claim each month. At the end of the 12 months, and this is where the outcome alignment comes in, the question is, did they improve that patient relative to where they started? And that's what they need to do in order to earn their full payment. Very specifically, and we can get into all these details, but we announced what's the minimum improvement that needs to be achieved to earn your payment or get them to goal. But it's really about not micromanaging how is care delivered, but rather clearly communicating and measuring what we expect to see, and then giving the clinical organization the flexibility around how they get there. And that's really where innovation can shine. And that's really what this model is introducing. Now, one additional point that's worth mentioning is that this is partly about how do we create this on-ramp for new ways of delivering care. And that's what outcome aligned payments that we're introducing in this model really does. The other is how do we ensure that that type of care extends natural care delivery or traditional care delivery and integrates with it. And that's important for 2 reasons. One is that it's better for the patient. And it's also, frankly, better for these organizations because it meaningfully reduces the customer acquisition costs and ensures that this becomes an embedded part of how care is delivered today. And to do that, firstly, because all of these access organizations are all Medicare enrolled providers or suppliers, that means that overnight, if you're a primary care physician and a patient walks in who has, let's say, high blood pressure and depression, you can immediately go to them and say, hey, there are all these new covered options under Medicare. Let's find the best one for you. You can go and look at this directory that Medicare is going to be, that CMS is going to be maintaining of all the organizations in the model, all the conditions they treat, and their risk-adjusted outcomes. That PCP can now say, let's sign you up for this great organization here. Make it really, they can just go to their website, sign them up. And don't worry, I'm going to be kept in the loop because I being the PCP, because that
You agree
access
with the data?
organization, as a
Yep,
condition of participating, needs to share updates. And we can get into all these details as we go further, but
yeah,
it's obviously a pretty robust summary of the model as well as some of the context for it.
for sure. It's obviously the when the model first came out, industry applauded the movement towards outcome-based payments and looking at that. We'll get into in a little bit the rates and how you think about those relative to industry expectations. But before we get into that, I'd be curious. So as I understand it, model goes live, I think July 5th. So companies are applying by, is it March 20th? Is that the date they're applying by?
The first deadline is April 1st.
April 1st. Okay. So they apply by that. They figure out if they're in the program. It goes live July 5th. I'd be curious both on the patient side and the participating organization side. Like July 6th, when this thing is live, what happens for a patient? Are they going to be inundated with marketing materials from companies trying to acquire these patients? Are they like, how do you see this rolling out kind of in real world from a patient facing side of the equation?
Yeah. Well, so I think what the state of the world looks like, well, I'll maybe contrast the world today and then a post-access world or once access is live. What does it look like today? Today, that patient I described earlier who has prediabetes and depression, if they're lucky enough to have a primary care physician, which many do not, they walk into that practice and that PCP can do what? They can typically write them a script. They
Mhm.
can encourage them to eat healthier. They can hopefully get them a referral to a specialist if that's possible. In an access world, what's different? Well, that same patient, when they walk into that clinic, the PCP can now say there are so many more options that exist for you to get care that the PCP can inform them and use as almost tools in their toolkit to support their patient. I described earlier that directory. CMS is going to be putting the full force of the government around creating awareness around this program so that every PCP, every really referring clinician is aware of these new care options. And importantly, yes, every beneficiary, every patient as well is aware of these options. Now, of course, CMS is not in the business of picking winners, so we're not going to be promoting any given solution, but we're going to be promoting more generally or creating awareness around these new care options. Certainly the list of the organizations and their outcomes will be a key part of that. We're going to be making that data available not only at our own directory, but also it'll be available at data.cms.gov so other organizations can ingest that and use that for their own purposes. So what that world will look like, right, is one where the patients and the PCP's first reflex is not if, it's which of these organizations I want to be working with. And it's informed based on which ones are going to be delivering the best health, are going to help me most.
Yeah. It's fascinating to, having lived in a health system for a few years and try to drive digital health adoption, that encouraging that behavior of, hey, PCP has a relationship with patient, they are going to be incentivized to refer out to a list of digital health solutions it's a really intriguing model, and I'm excited to dig into more of the acquisition side of the world. Before we do that, I'd be curious to go to the conversation around rates.
Yeah.
I'm sure you've seen the reaction, social media, lots of folks being like, "Hey, so Oz when the program was announced, talk about he had that quote of I say with great desire to highlight that we want people to make money building these solutions. We are open for business. We want you to be open for business." So I heard that quote. I then heard. I think it was Chris Klomp at JP Morgan talk about how he was really excited for access because the way the rates were going to be set was to drive the insurgents in the industry and set it in a way that incumbents can't just operate with business as usual. We want to try to drive this change forward in a meaningful way. If you look at MSK, mental health, CKD rates today, and you compare it to what a industry participant gets paid current state, obviously that rate is significantly higher than what is being paid in access. How do you conceptualize where the rates came in and what that is intended to incentivize from a behavioral perspective for the industry and who you expect to be participating in the model?
Yeah. And I mean, I will say that I think Dr. Oz and Chris both described exactly the way that we're looking to approach this, which is that both those things can be true. We
Mhm.
want to structure this so that organizations that are innovating around how do we deliver meaningfully better care at a lower cost are able to massively to thrive and scale. That will be true. And at the same time, it will also reduce costs for the system because the organizations that are delivering care in this way will just have a very different cost structure. So that's really what the rates reflect. I saw somewhere someone had written, I'll just read out the quote. It's sort of interesting seeing industry reaction to one's own thought product. But I think this person sort of summarized it pretty well, which is that, CMS is structuring access as a forcing function for innovation where the payment rates are set at levels that require technology-enabled efficiency to achieve profitability and are interesting, exciting. And then the outcome requirements ensure that only interventions producing genuine clinical improvement survive. And that's really the way this is structured. And that scaling opportunity is a really big part of this, right? We're not we've obviously removed the activity-based reimbursement shackles that have held back efficient care delivery. That's been removed. We're now offering this scalable opportunity where organizations can directly acquire patients. They can, and we're investing around that referral mechanism. So there'll be an opportunity there. This is within original Medicare, which is 30 million patients. I described earlier the size of that market opportunity in terms of 70% plus having conditions. And then we announced, as you alluded to earlier, we announced last week that pretty much every payer in the country, certainly the major ones, committed to adopting an access-aligned payment option. That's 165 million additional members. So this is a extraordinary TAM. We've really blown open the market opportunity, and it's just a question of which are these new organizations that are going to seize that opportunity.
Yeah, it's an interesting way of framing it that I haven't seen a ton, but it's like, okay, if you think about opening up 70% of the original Medicare market to these sorts of toolings, and even at the lower rate, I haven't done the specific math on it, but you're still talking about billions of revenue opportunity for companies coming in to operate in this space, if they're able to figure out how to operate successfully under this model, right?
Exactly. And by the way, the opportunity, solving for that, which I will say point blank, is possible. And we will see that become the competitive moat for these organizations. So that's really the opportunity. We're not trying to pay our way to savings here. What we're really doing is we are opening up an opportunity for organizations that will rise to that challenge, and they will thrive. That's what this model is really doing. By the way, one thing I just wanted to circle back on briefly, because we talked a lot about this, the integration with traditional care. I didn't say this explicitly, so it's worth mentioning. So we did also introduce a new co-management payment. Or in that example I was giving earlier, that PCP, they are able to bill a standard normal fee-for-service code for documented review of that care plan when it's pushed to them by the access organization and one care coordination activity. It's relatively lightweight, so they can get paid. And then also if they're in a risk-bearing arrangement, if they're, let's say, in an ACO, because the access organizations are submitting a standard claim, the ACOs already can benefit financially because it better helps them manage total cost of care, and it comes out in the financial reconciliation. So it sort of nests within ACOs. And then we also announced in the first year and a half of the model until 2028, the expenditures that are associated with access are not counted toward the outcome aligned payment expenditures are not counted towards the expenditures within the reconciliation process for an ACO. So that means that I would say in the first years of this model, when it's really a greenfield opportunity, there will be organizations that move quickly, that there's a unique moment to really fill that and become the organization of choice for these referring entities.
Yeah. So if you're an ACO, you have a strong financial incentive to refer out to these entities to help manage costs in a way that isn't counting against your ACO calculation, which should be kind of a win-win for both parties in that scenario, right?
Now I by a third party, which is the patient, because
yeah, for sure. Yeah,
I'm only saying that because I actually feel pretty strongly about the nice thing about outcome aligned payments is that because it rewards health, and we know that savings will rise. We know that if you reduce someone's A1C by 1 point, there is a 1.7% reduction in total cost of care. We know those things, but we want the clinical organizations focused on improving their health, and that's what this model will enable.
Yep. So can I I'd be curious. You mentioned going out having a whole bunch of conversations with industry. Yeah. I'd be curious. imagine you're talking to independent PCP who's like, hey, Jacob, this sounds really cool. I'm all on board with outcome aligned payments and technology and all that stuff. And I am so overwhelmed and so overworked and so underpaid today that like I just can't process how to do all
Yep.
of this stuff in a model like this.
Yep.
What would you encourage them? Like, how do you think about driving adoption with those PCPs? I know there's the payment that seems like a good, carrot in terms of adopting this, but how do you process that conversation for a typical PCP in this country?
Yeah. Well, I think doing something different is really a function of at least three things, right? You have to be aware of it.
Mm-hmm.
You have to have a reason to do it. And the cost to you of doing it has to be low enough, right? That it's not going to be burdensome. And I think all three of those we're going to be either investing in or have already structured. So on the awareness front, this is where it helps to be representing CMS. We have a lot of levers at our disposal to massively increase awareness amongst that population. We'll also be working with, societies, and we announced this at the Access launch event in December. A lot of the clinical societies signed on to a statement of support that included the American Academy of Family Physicians and others. So we're going to be doing a lot around the awareness side. So that's the first piece. The second is the why, the incentive. And yeah, some of these things are definitely nice, considerations like the co-management payment. Is that going to, massively move the needle for the economics? No, but $100 per patient per month, if you have a, 2,000 patient panel, that's a nice amount of incremental revenue. That's interesting. And importantly, and this is the third point, the friction or lack thereof associated with this is relatively low. So in contrast to other types of arrangements where you need to maybe assess different solutions, enter into complex relationships, subcontract with them, shared savings, none of that applies. This is a single code in that case that they can bill for documented review of the care plan and the like. Other things that are just interesting flywheels here, by the way, that proactive sharing point of the care plan, well, that's going to increase awareness as well around this program, because you can imagine an organization that receives this care plan, and the template will say at the top, something about this program. So there'll be a lot of awareness, and the action itself that the PCP needs to take is relatively low friction, and it's in their self-interest. And I will say the fourth piece is that I do personally firmly believe that clinicians do want to help their patients, and they're also going to be looking and saying, wow, this solution reduces their weight by this much, it improves their A1C. Wow, I want to refer my patients to that. So I think they can really win.
Yeah. How do you process in that one of the pieces of potential risks, it seems like, in this model is that the way it's set up, you can encourage just GLP-1 prescriptions as a way to drive better outcomes. And, there's the perception of pill mills in the industry and whatnot, just prescribing more and more under something like this. How do you perceive that risk as part of this program? And how do you look at that conversation?
Yeah. So generally speaking, the coverage for a given medication, those guidelines should be informed by, if they're eligible, we determine that it is both actuarially worthwhile and we want them to be, if they're so inclined, taking this medication. So to the extent that the guidelines allow for that, and these organizations will potentially, if it's in their approach, be prescribing a given medication and supporting with the adherence, one could argue that that's certainly what actually one wants to see. Because at the end of the day, the question is it working? Is it reducing their LDL? Is it, and the like? So that's sort of the first answer. We're going to be informed choice is a big part of this model. Not everyone wants to be on taking medications for various conditions. In the risk-adjusted outcome directory, we're also going to likely be including some sort of derived measure of their use of medications, not in a punitive way, more in an informed way. So people can say, oh, this organization achieves this much of an improvement, and 85% of their patients are on medications. This one achieves similar outcomes, but only 5% of their patients are on condition-specific medications. So that way, at least patients can make informed choices there. In theory, the model can extend to this idea of some sort of non-pharmacological outcome attainment bonus or something like that. But that's not part of the model design right now. It's really about improving the outcomes. And if medications get you there and it's covered, then I would argue that that's still a win.
Yeah. A couple more questions for you, and then I know we're getting close to time. I'd be curious about the digital health community and perception of digital health community and coming into this program, and how they think about that, and almost what seems like a bit of a innovator's dilemma for them in terms of, hey, they've been working with the employer population, getting paid higher rates by the employer population, and now they've got opportunity to come into Medicare, but at a lower rate. How do you think about conversation with that section of the industry and how they're thinking about the opportunity here and what it takes to succeed in it?
Yeah. So it's funny. I almost hear that question is like, well, how do the incumbent digital health organizations think about this? And I would almost argue that there's not really yet any such thing as a truly incumbent digital health organization. If you look at
Hmm.
the percentage of healthcare that is spend and patients touched that runs through digital health organizations as a percentage of the total, it is so small. What we have basically done as CMS is we have 100x, if not more, the market opportunity. We've also made it a more competitive, transparent, level playing field. So I think any organization, whether they're an incumbent or whether they are a new entrant altogether, or maybe they're a company that's founded today that is looking at this opportunity, will recognize that they are the most they're the most agile here. And I would be personally running as actively as I could to, yes, potentially rethink my cost structure if it's a little bit oriented around, the 1.0 digital health. But I would see what looks ahead, which is a 100x greater market opportunity.
Yeah, that makes total sense to me. Last question for you before talking through kind of some of the logistics of the program and how companies
Yeah.
participate. Spillover effects from CMMI. There's been conversation over the years about how effective CMMI has been at proving cost savings from models. And there's one of the points that I often hear made is, well, you can't just look at CMMI. You have to look at the implications CMMI activities have had on the industry writ large in terms of value-based care impacts, so on and so forth. It was interesting in that regard to see last week the news beyond just the rate announcement that y'all are bringing in payers, as you mentioned, who have agreed in principle to think about rolling out this kind of outcomes-based payment as well. How do you, in designing a program like this and thinking about rolling it out, how do you think about those spillover effects? How are you looking at that kind of over time in the access model?
I hope this will redefine how we think about healthcare and our expectations of it. And part of your question relates to, well, how do we ensure that like the actuaries give the model credit for that spillover
Hmm.
effect? And there are ways that they can effectively do that. But my hope is that the positive impact on health or quality and costs, even just within the original Medicare population, is so beyond a doubt that this model in the language of CMMI will be certified very quickly. And there are probably other ways of determining through natural experiments or other ways trying to quantify the spillover to the rest of the industry. But importantly, as you said, this is becoming the dominant way that people think about paying for technology-enabled care, which, by the way, at a certain point will just be called care. Like you don't think about, oh, is my bank technology-enabled or is it a
For
brick
sure.
and mortar bank? You just think it's a
That's
bank.
just my bag. Yeah, totally.
So I do think that this is, at least as it relates to chronic conditions, that this way of paying for outcome-aligned care will really be the dominant dominant approach, and we're seeing that from announcements like this.
Yeah, that's awesome. So for folks in the industry looking to follow along with the model, looking to participate in the model, can you walk me through the timeline from here, big milestones, what people should be keeping an eye on?
Yeah, certainly. So as you alluded to, the model goes live to patients in July of this year. The first application deadline to apply is April 1st. I mentioned earlier one has to enroll in Medicare and the like. If one hasn't completed enrollment, you can select that box in the application that it's in process, and that is not blocking of applying. It will be blocking of being able to sign the participation agreement. But that's worth mentioning. The model does have rolling admissions, both for organizations and the patients that they enroll. So it's a 10-year model. And organizations can continue to apply beyond that deadline. But of course, there's a first mover advantage, I would imagine. So those are some of the upcoming timelines. One thing we didn't touch on, but it's worth mentioning as an adjacent piece is what's called the Tempo pilot.
Hmm.
So I'll just give a tiny bit of context. So the access model basically says that you got to follow the rules of FDA. FDA has recently come out with guidance that narrows their focus to the highest risk, what are called devices. So I would recommend looking at the wellness guidance and clinical decision support (CDS) guidance that says a lot of scenarios fall under enforcement discretion, do not require pre-market authorization. Some do require pre-market authorization that are higher risk. For those types of technologies or devices, there is a parallel pilot that FDA is running called Tempo that FDA will agree that if that device is used in the context, I'm using the word device, by the way, broadly, it can be a software or hardware device. If it's used in the context of access, then FDA may agree under an approved plan that it can be used without requiring that pre-market authorization with the evidence captured in market in a real world setting. It's a really exciting opportunity to be bringing exciting new technologies to market more quickly. The deadline for that, I believe, is relatively imminent. There's 40 spots that they've announced there. So I would recommend people to look at the FDA Tempo website for information on that front.
Yeah. Exciting times. There's certainly a lot going on over there. Excited to see kind of how the model progresses and what we learn from it. And looking forward to seeing who's participating as well. Jacob, thank you for spending the time this morning talking it through, and enjoy the day.
Thank you. Same to you.
All right.